Interrupted aortic arch is a relatively rare congenital condition in which a portion of the aortic arch is absent. Interrupted aortic arch comprises only of 1.5% of all congenital heart defects. Approximately one half of the patients with interrupted aortic arch have homozygous deletion of the chromosome band 22q11.2 associated with DiGeorge syndrome. Interrupted aortic arch is frequently associated with posterior malalignment VSD 80% and some degree of subaortic narrowing due to posterior deviation of the conal septum. The diminished fetal blood flow through the ascending aorta is thought to contribute to development of discontinuity. However, the abnormal blood flow alone is not thought to be sufficient for development of interrupted aortic arch. Interrupted aortic arch is classified based on the location of interruption. Type A is between the left subclavian artery and the insertion of the ductus arteriosus. Type B between left subclavian artery and left common carotid artery, and type C between left common carotid and brachycephalic artery. In the modern era, the prenatal ultrasonographic diagnosis of interrupted aortic arch is increasingly common. However, when the patient lacks a prenatal diagnosis, they may present with cardiogenic shock as ductus spontaneously closes. The myocardial injury may result due to the profound acidemia as present. Echocardiography is sufficient for the diagnosis. Important echocardiographic characteristics to obtain are the length of aortic discontinuity, narrowest dimension of the LVOT, diameter of the ascending aorta, and presence of associated VSD or the PFO. It's clinically important to assess the patients of DiGeorge syndrome. Until this diagnosis is excluded, only irradiated blood products should be used. Prostaglandin infusion should be initiated upon the diagnosis to maintain the ductal patency. Definitive treatment is surgical repair. The baby should be supported as needed with mechanical ventilation and inotropes. The pulmonary overcirculation should be treated through the use of afterload reduction along with minimal FiO2 and the avoidance of the hyperventilation to limit the pulmonary vasodilation. Without the medical intervention, the medical survival is 4 days. The aortic arch reconstruction is achieved by direct anastomosis with or without additional patch aortoplasty. Closure of the VSD or resection of any prominent coronal tissue is needed. Historically, two-stage repair was performed by repairing the aortic arch and placing the pulmonary artery band. Current standard approach is one-stage repair with direct anastomosis of the repair of any intracardiac defect. A 30-day post-operative mortality is reported between 10 and 15%. Intraoperative correction is accomplished by a dual arterial cannulation of the ascending aorta and ductus arteriosus along with the bicable cannulation, and the intracardiac repair is necessary. The use of the deep hypothermic circulatory arrest or the regional cerebral perfusion in center dependent with the no demonstrated superiority of either approach. The aorta with widely mobilized all ductal tissues is resected, and the direct continuity between the distal transverse and the proximal descending aorta is achieved with or without additional patch augmentation. After aortic patch repair, any associated VSD or subaortic narrowing is addressed. After the interrupted aortic arch repairs, largely the outcomes are determined by the associated cardiac anomalies. The greatest survival in the patient with interrupted aortic arch and VSD with no other abnormalities is 86% 30 days survival, 70% 5-year survival. Freedom from reintervention for the arch obstruction in patient undergoing the direct anastomosis is approximately 86% at 3 years. The most common indication for the reoperation in subaortic stenosis occurring in approximately 20% of the patient, with the next most common being recurrent aortic arch obstruction. Thank you.